So first of all, I will introduce my own presentation. Then Javier Salvador from the Navarra University will be presenting his work on GLP-1. And then Emiliano Bruner, working at the CSIC and also affiliated to the Fundación CIEN, will be presenting his work on neuropaleontology or something like that. I don't even know how to define his specialty. Okay, so I'm going to start now with my own presentation. My idea is to give an idea, an overview of what has been my work over the years on insulin peptides in the brain. So this is the neurobiology of insulin peptides. Okay. So we have been working with the physiology of these peptides in the brain, but with a keen interest in whatever we learn of the physiology of these hormones to be implemented into a clinical usefulness. So that's why I'm saying from bench to bedside, I'm going to describe this process. And for that, I have to be very brief on most of the topics I'm going to show you. So these are my disclosures. I also like to start with this type of slide because it really shows how conserved is the system of insulin peptides. There is a family that is already present in invertebrates, and I always say the same example. The human insulin is able to interact with the worm receptor. So this is highly conserved hormones, which usually means that they are, from the biological point of view, quite important. So the organization of the system is as it is previously described in the slide. So we have a multi-ligand system in invertebrates, over 40 ligands in the C. elegans. Then we go on one single receptor. And then in other invertebrates, more modern invertebrates like the fly with the model organism, the Drosophila melanogaster, they only have 8 ligands, and although it's mostly recognized one single receptor, but it's been described by the people in Alicante that there is a second receptor. And then in vertebrates, and this is mostly work done in mammals, but all vertebrates have more or less the same organization. We have 10 ligands, more or less. I say more or less because they are not well defined yet. And then for each ligand, there is one receptor with high specific for each of the ligands. In the brain, the main ligands in the mammalian brain are the insulin, IGF-1, and IGF-2. All three have a wide distribution of receptors, which, from a simplistic point of view, we may say that if they have so much receptors all throughout the brain, including the spinal cord, that would mean that they have real important and widespread effect on the brain. When I started working at this field, IGF-1 was considered not to be a neurotrophic factor because it was supposed not to be present in the brain at all. Actually, the expression of IGF-1 in the adult brain is really very, very low compared to other neurotrophic factors. But anyway, the mere presence of these receptors all throughout the brain, actually the brain is one of the organs with highest content of IGF-1 receptors. So that would mean, from a very, very easy explanation, that they have a wide effect. So classically, when we started with this field, neurotrophic factors were important modulators of brain development. And it is well known that ILPs are neurotrophic factors, meaning that they have a number of effects during the development. This is a short description of each effects of IGF-1, and IGF-2, and insulin. They have specific roles for all types of brain cells in the development in information and circuits. So these peptides are important for brain development. But we are not interested in brain development. We are interested in the physiology of the adult. Still, at the beginning, we start looking at the developmental effects of IGFs. Now, a detailed analysis of the receptors, and I was surprised because in the field, the description of the receptor was done a long time ago using in situ techniques and so on, but there was no detailed examination of these receptors through a different type of cells. So we did this quite recently, like 3-4 years ago only, showing that all types of brain cells, neurons, microglia, and so on, have, at least in the study we were conducting, because we are focused on insulin and IF-1, all of them have these receptors, and they also have these hybrid receptors, this insulin receptor and IF-1 receptor are able to combine, which is kind of striking, and it's not very well defined, the role of these receptors. But anyway, so all cell types in the brain express these receptors for insulin and IF-1. This is also very significant. Now, one thing that we realized a long time ago is that if you inject, well, it was well known for insulin, by the way, because insulin has been described a long time ago that it's produced in the pancreas mostly, and it goes into the brain to regulate feeding and glucose handling and so on. So it was described very, very shallowly that insulin is able to cross the brain barrier. In our hands, we realized that IF-1 surely was also transferring from the blood into the parenchyma, but it took us quite a deal to convince the community that indeed these receptors are located in the right places from the anatomical point of view, meaning that they are sitting in the barrier, in the endothelial cells, and in the glial end feet that are wrapping the endothelial cells. So we described by VIII, and this was in collaboration with Antonia in Malaga, which is the audience. Before we had already described the presence of IF-1 receptors, by the way. But anyway, so the point is that both insulin and IF-1 receptors are sitting in the right place to be able to capture insulin or IF-1 from the bloodstream and transfer it into the brain parenchyma through a process that is called transcytosis and is highly regulated. So these receptors are capturing, taking up from the bloodstream insulin and IF-1. And the major source, quantitatively speaking, of these hormones in the brain are coming either from the pancreas for insulin and from the liver for IF-1. So this is a description that we made of these routes of entrance. Formerly, we examined the blood CSF route because we found our data were showing clearly that, at least for IF-1, is getting to the CSF. The CSF is containing all these hormones and many others. It also contains the carriers of these hormones, the binding proteins. So there is a flux of IF-1 and insulin. No, for insulin, we didn't do the study, so although insulin is present on the CSF. But anyway, for IF-1, it's able to go through the barrier at the epithelial layer here, which is making the barrier. And for the endothelial barrier, again, IF-1, and in this case also insulin is able to go through the barrier. And what we have described is the mechanisms underlying this capture of IF-1, and this is activity dependent. This is an important point. So whenever the brain becomes active for whatever reason in a given area, it will accumulate not only nutrients and oxygen, but also IF-1 and probably most likely other growth factors. So this is a transport system which really kind of surprising because at the same time, the brain is producing, although at very lower amounts, IF-1 and insulin. So this is double origin of these hormones, which is, by the way, a common organization for many neuroactive hormones, like, for instance, steroids versus neurosteroids and so on. So this is a summary of what we have been describing, we and others, of course, of the way IF-1 in this case, because our most detailed analysis has been always for IF-1. So the IF-1 is going through the third ventricle into, for instance, the tanycytes in the hypothalamus are able to accumulate IF-1. Importantly, there is pre- and post-synaptic receptors for IF-1, and IF-1 is working at the synapse, and we have abundant evidence of this. So it is a neuromodulator, and it's a concentration-dependent effect. Then again, importantly, it's a neurotrophic factor, a neuroprotectant. So that means that whenever there is an injury, and this has been well described, extensively well described, that whenever there is an injury in the brain, there will be upregulation of IGF-1, binding proteins, and so on. So the system is upregulated in response to injury. And in this case, it's mostly produced by activated microglia. And then again, this entrance from the blood, which is our favorite way, because it took us such a long time to demonstrate this, that we are really happy with finally showing that IGF-1, and again, insulin is transversing the blood-brain barrier, getting into the brain. So highlighting the major actions that I want to show you today is, first, IGF-1 enters into the brain upon demand, and then in the brain, whether it is from the outside or inside the brain, because also interneurons and other cells produce IGF-1, is an important factor modulating sensory perception. And this is for all kinds of senses, for hearing, viewing, and so on. Okay? So this is a general modulator of sensory activity. So looking at this striking, at the beginning, entrance of IGF-1, we went to look into physiological meaning of this mechanism, and what we found, taking some knowledge from the muscle, from the periphery, we found that exercise is a stimulus for the uptake of IGF-1 from the periphery into the brain. This is so we put mice, in this case, running in the treadmill. These animals like to run, so they spend running like for half an hour with no problem. After running, they accumulate IGF-1, this is immunocytochemistry in various regions of the brain, because this accumulation is dependent on the active region, but for the exercise, many brain regions are active. So like in striatum, cortex, or red nucleus, this is only to exemplify that this is widespread accumulation, and this is the control. A sedentary mouse receiving IGF-1, systemic IGF-1, accumulate in the same region. So this accumulation, in this case in response to exercise, which is a physiological stimulus, is focused on given cells, and we documented that these cells are neurons and so on. So there is a physiological mechanism of this entrance, which is one, exercise. There are others. For instance, the environmental effects of this capture are well documented by us and others. So whenever a brain area is activated, for instance, because they have partners in the same cage, that will activate the system. This is only just to document one of the examples. In this case, we did this in collaboration with Professor Núñez in the UAM. What we did was first document in a slice preparation that IGF-1 is modulating a theater of neurons, which is, this was our original publication, but later on, this was like 2003 or something like that. Then many other labs have shown that IGF-1 is a general activator of neuronal activity and through various means, using a number of mechanisms. But in general, it's a general activator of neuronal activity. And in terms of function, what we have found is that if you stimulate the point in this case, and then before we check the cortex that is sensing this activation of the pole, this is the effect at the control conditions, and when we give IGF-1, systemic IGF-1, the amount of neurons that become activated by this stimulus is enlarged. So IGF-1, when entering into the brain, increases the activity of neurons, and this means in practical terms, in functional terms, that they become more sensitive to, in this case, to the pole stimulation, to somatic stimulation. And this was done recording in the barrel cortex in the mouse. So looking at these effects, and this is just one story, what we realized, and this was in part responsible, my colleague at the Cajal convincing me that we had to do something with the cerebellum. And this is the background information why we started looking at the cerebellum. First of all is that IGF-1 is an important factor in cerebral development. Also in the adult, we documented a number of effects in the adult cerebellum. Importantly, IGF-1 is altered in many and very diverse cerebral pathologies, most of them of genetic origin. And then in animal models, including ours, and this was formerly our work, it has a protective action. So these were all the reasons we had, and I'm going to show just one experimental model. We started this using a neurotoxic model of a cerebral ataxia, which is kind of very primitive, but this is an old experiment. What we did was inject this toxin, which kills mitochondrial function, and then we get, we get this type of low calvinin activity. This is the inferior olive nucleus that is branching into the cerebellum. This toxin kills these neurons, so the number of neurons are decreased, and at the same time, using this behavioral technique of the rotary rod, these animals became completely ataxic, meaning that they are unable to get fixed into this rod. But when we give the animals, this is the control situation, so after a while, then the control animals are able to stay in the rod for as long as this test lasts. And then when we give the animals that have already received the drug, slowly, throughout the time of treatment, either if we give it systemically or centrally directly, the recovery is full after a while. So, and this we documented how was this recovery through branching of new connections between the inferior olive and the cerebellum. So this was a typical restorative effect of IGF-1, which was in our hands was really very striking, but there were many experimental models showing that IGF-1 is a neuroprotector. Okay. This again, just to put it more into a physiological context, we examined the neuroprotective action of exercise regimes in a number of different conditions and diseases. In this case, we were using inherited cerebral disease, which is a Purkinje cell degeneration model, a mouse model. And we find that in response to exercise, the cells recover. In this case, our Purkinje cells, which are dying. After exercise, the animals that are doing exercise maintain the Purkinje cell population. But when we deliver a blocking antibody for IGF-1, the protective effects of exercise disappear, meaning the easiest explanation is that IGF-1 is participating in these protective actions of exercise. And we know that exercise is stimulating the entrance of IGF-1 into the brain. Okay, so for this reason, we went to try a therapy in patients of cerebral ataxia. And for this, we obtained the support from the Patients Associations of Ataxia in Spain. This is a number of diseases of genetic origin that have no treatment whatsoever. So this was like a big hope at that time. It took us years to be able to set up the whole assay. We selected based on the neurologist advice. Well, we were doing this, of course, with neurologists, in this case in La Paz, with my friend Javier. And they chose this type of patients that are well before they go into the wheelchair, because these patients are always going to the wheelchair before they die. So we treated the population. This is just one sample with 5 patients. Altogether, we treated 45. And we were able to treat them for one year, which is shown here. And after a year, the company that was providing us the IGF-1, in this case, decided to stop the trial. So what happened is that all the patients went up. This scale, the clinical scale, higher scores means higher disease, okay? So this was showing that IGF-1 for 1 year was able to keep the patients not getting worse, but if we interrupt the treatment, then the disease recovers natural history and the patients just go on the disease. So this was showing us that, of course, these patients already have neuronal loss, so this cannot be recovery. So they at least have a reasonable quality of life at these stages. Okay, they are not okay, but at least they can make a almost normal life. And this was published, but anyway, this was suspended because there was no sponsor that was interested in using IGF-1 for this type of diseases. IGF-1, this was a repurposing because IGF-1 was and is already used in the clinic for endocrinology diseases. So this was kind of frustrating. We just even started our first spin-off with no big success, actually. And then we went on, of course. And this is not that we just all of a sudden decided to work in Alzheimer's disease. It is that our work on these peptides led us to Alzheimer's disease. And I will explain very briefly this. And the reason is that, first, IGF-1 is a wide-spectrum neuroprotectant. This is well established. Actually, I think that IGF-1 is now considered like a prototype neuroprotective factor. IGF-1 is also known to modulate cognition and mood, and we are not going to get into this because it's a quite complex field. And it is well known that the system, insulin, IGF-1, and IGF-2, are altering AD. The significance, the biological or pathological significance of these alterations are a matter of great controversy, but anyway. And we have shown in different ways that IGF-1 seems to be involved in AD pathology. So that were the reasons we decided to go into animal models of Alzheimer's disease, and we are well aware of the limitations of animal models, but that's what all we have. And in this case, we were using the mouse model, the double mutant APPPS1, which is very popular. First of all, before doing any experimental model of Alzheimer's, what we found, and this was one of the reasons we got into the topic of Alzheimer's disease, that we found is that while we were examining the transport of IGF-1 from the blood into the brain, and in this case it was through the CSF, this was our formal focus was into the CSF because that was our first observation. In this case, what we found is that there is a process whereby IGF-1 is entering into the brain, into the CSF, and gets a number of proteins, which are all of them involved in amyloid clearance. And this is not just chance. We started with albumin, which is the prototype protein that you are going to examine. Albumin doesn't get into the brain so easily, but it's transported in a specific way. So we found this type of proteins, all of them carriers for A-beta. Then this was the process, and this was a time-lapse analysis showing that after a longer time, we found these proteins getting bound to A-beta in the parenchyma. Later on, these complexes get into the CSF, and eventually they go into the bloodstream. So through this process, recruiting these proteins, IGF-1 is stimulating the entrance of these proteins get into the brain, bound A-beta, and then eventually so this is a clearance mechanism. We found this, and this was corroborated by other people. When we published this, there were people in La Roche that were very enthusiastic about that. They first confirmed our findings, and they even started to think about using this for Alzheimer's. But anyway, that didn't go too well either. So another observation that we had, and this was also a long time ago, is that if you know some of the pathways that are implemented by IGF-1 to be a neuroprotectant, and in this case what we found is that IGF-1 is modulating inflammatory signaling, in this case not in the microglia, as we could expect, but in the astrocyte. So astrocytes are using this pathway through the master regulator of inflammation, NF-kappa B, and this is a dual and ambivalent pathway in the sense that with positive stimuli such as IGF-1, there will be an anti-inflammatory pathway, but with inflammatory stimuli such as TNF, and this we recommended using TNF-alpha, it will be the opposite. There will be an inflammatory cascade. And for that, what we did was to produce a mouse that was mimicking the effect of IGF-1. And this mouse, this was a TET-off system, which is, we call it here the ICAP mouse. We use the APPPS1, and our mouse combined with the APPPS1. And what we found is that throughout the time, in the regular mouse, there is accumulation of plaques. But when we turn on the pathway dependent on IGF-1, just by modulating the tetracyclic system, then the advance of the plaque formation is much slower, while in the control condition is kind of exactly to the no activation. And this is a reversible effect that means that if you treat the animal, in this case, for 5 months, with the system, with the tetracycline, then you get off the plaque formation. But if you just stop and get back in the same animal, back to the absence of this activation, then the animal becomes also with plaque. So this is, in this way, we were able to show that this was reversible. The process of beta accumulation in plaques was reversed by modulating the inflammation that was a pathway in the astrocytes, not the microglia. This paper was, from our point of view, one of the papers that was documenting that inflammation is also important for Alzheimer's disease, at least in the animal model. So we went on this just to show that using the regular IGF-1, we were able to clear the plaques in this mouse model. In another mouse model, again, we found this clearance with IGF-1 treatment. We treated different mouse models to be sure. Of course, we also found effects on behavior. In this case, it's in the wire maze for the mouse, both in the acquisition and in the memory. The treatment with IGF-1 was beneficial. So what we reflected was the fact that, and this was a number of different studies, that during the process of aging and in disease, there is a common thread that is loss of activity of IGF-1, both combined with an IGF-1 deficiency, so the older we get, the less IGF-1 we produce, and at the same time, the less sensitive we go to IGF-1. This is I always show the same example. It's like type 2 diabetes for insulin. So not only the brain, but all organs in the body lose sensitivity to IGF-1 throughout time. So this is a trait associated to aging. And what we characterize in this case were two kinases involved in this loss of activity. It is well known that loss of sensitivity to insulin is recruiting a number of kinases that are affecting the insulin pathway transmission. And these same kinases are the same as for the case of IGF-1 because the receptors are very, very similar. So whatever you see that induces insulin desensitization will be also inducing IGF-1 desensitization. But we reported specifically these two targets, the P38 MAP kinase and the YUN kinase. And we decided, again, to try with a new adventure. So, in this case, I learned from the first failure. So in this case, we just went through more prepared, at least mentally prepared. So we produced a startup from the Spanish Research Council, and of course with many other people. And we got the idea of doing a clinical study. But in the meantime, although we haven't reached that time, that yet, and we are still far from that. First of all, we produce one first compound, which is decoded here with this name. We saw that indeed this compound is an allosteric inhibitor of 5p38, a new kinase, is increasing the sensitivity to IGF-1. Once you desensitize the cell, this is in vitro, a culture of astrocytes that when exposed to LPS and inflammatory stimulus, they lose the response to IGF-1. This is well documented. This is not our finding. And when we provide this compound, the sensitivity is restored. We are the surrogate marker of activities phosphate AKT, which is downstream of the IGF-1 receptor. Importantly, and this is really very important, this compound is able to go through the blood-brain barrier. And this is work done by other people. So we have a compound that is modulating IGF-1 sensitivity and at the same time is going through the blood-brain barrier. So we just tried a proof of concept of this compound in vivo. It is well known that in the mouse at least, the response to IGF-1 a long time is lost. What we had is a very nice in vivo assay for this sensitivity of brain responses to IGF-1. When we inject IGF-1 in the periphery and we record the brain activity through the EEG in the mouse, we see that this modulation of the main bands, delta, theta, and so on, all are increased except for delta, which is decreased. But in the older mouse, the older than 18 months, this response is kind of much lower. So in our hands, we see that this mouse, old mouse, is losing the response to IGF-1. And under these conditions, we went to to a parameter that is sleep. Sleep is, as you know, affecting in the older population, like 50% of the population is having sleep problems. So in the mouse, it's more or less the same, although the sleep patterns in the mouse are quite different from the human, but still, we saw first one thing, that one of the nuclei that are involved in the sleep regulation, and this is well known, is orexin nucleus, which is a small nucleus in the hypothalamus. Patients without orexin have this disease, which is that you can't sleep anywhere. So this is a big problem for them, and this is because they lack orexin neurons. So orexin cells are important for the regulation of sleep. In these cells, what we documented is that the IGF-1 receptor, not unexpectedly, shows a dysfunction in the sense that the protein is increased, and this is immunocytochemistry, and with RNA-scope, the in situ hybridization, the message is decreased. So, and it is well known through our studies and others that IGF-1 receptor protein is regulating its own expression. So this, to us, meant that this receptor is dysregulated in the orexin population in the whole animal. So what we did was just to use this compound. This is the sleep patterns of young mouse versus old mouse. Okay, so there is a decrease in delta. Delta is increase, meaning that the animals are sleeping. Delta is associated to sleep. And they have also more naps. But in the old, they have, contrary to what is known in the human, they have less naps. Okay, so they become asleep less often than in the young animals. The sleep in the mouse is fragmented. Okay, so it's very, very different from ours. But when we treat these animals, these old animals with the compound, we see that the patterns of sleep recover to juvenile levels. Like this is the yellow compared to the, so they look very much the same. And again, they recover, they go back to higher naps after the treatment. So this compound, by sensitizing IGF-1, which is being lost during aging, is recovering this sleep pattern. So this has a utility, well, we don't know, but this was just a proof of concept that our compound was acting as we were expecting. So as I told you, we founded this startup quite a while. We have a first hit with a chemist in Barcelona. They are really excellent professionals, really. I am just astonished how good they are. We got a first hit, and then we got 2022 a first publication with this compound. This is the one I just showed you with sleep. And then we were expected to have the phase 1 phase now in 25, but as it is usually the case, all the toxicology studies took longer, and now we have all the toxicology clear up, and then by the Q1 in 26, we will have the phase 1. And then eventually, since we have, and I cannot show you because of patent issues, we have good results with animal models FAD, we may tentatively start a clinical assay with ED patients that already have the disease. Not at early stages, but at more advanced stages. So the summary of my presentation is here. This is well known. We have contributed to this notion, but it is well known. This is a notion that we have really very much favor because it is not so clear, but we are very much convinced that, like in the insulin case, there is a loss of IGF-1 sensitivity in brain pathology. This has been also shown by many people, including us. And this approach, using small molecules rather than the IGF-1 itself, either by mimicking or sensitizing the system, have a promising therapeutic application. Like in diseases, I have documented just animal models for, well, not animal models, in the case of patients for cerebral ataxia, may be useful for this type of diseases. And we believe, as in many other cases, since this is a multifactorial neuroprotective factor, that in many other cases will be also effective. And this is my group, which is split up. When I moved to Bilbao, I was able to keep a little lab at the Cajal, and then I have this in Bilbao. And these are all major collaborations throughout the years, and thank you very much for your attention. Now, due to logistical issues, instead of waiting until the end for a round of questions, now each speaker can receive questions, okay? So the the stage is open for your questions in case you have any clarification. And if you don't, then we go to the next speaker, okay? Okay, thank you. So next speaker, sorry. Oh.
Beautiful talk. Thank you very much. And also, it's impossible to resume all your research for many years in a very short presentation. And it's about the things that you have no time to explain. And in fact, we were talking before the presentation about the scenario of that very short groups research and the crosstalk between all the key factors on Alzheimer's disease. So I think that will be good that you give us some view about the crosstalk with amyloid, with tau, thinking in the therapy. Because if you think that this therapy will be combined with other kind of therapies, and if, because you mentioned that will be for moderate Alzheimer's disease, I think, what do you think that is the moment to treat the patient with this therapy?
Well, we don't have that in so much detail because our findings are only based on animal models already developing the disease in terms of neuropathology plus behavior. So this is just not enough. To translate that into a human situation is going to take a while. Anyway, our hope is that it will be useful for patients that already show cognitive disturbances. This is our aim, mostly because this population has it's going to be like a orphan use because nobody's taking care of these patients anymore because they go early in the disease. As for the combining effects, I'm sure that we need to combine the treatments because IF1 is very multifactorial. It's addressing like tau pathology because it's modulating the kinases. It's addressing amyloid because it's modulating the clearance and so on. But still, I don't think it's quite optimistic to consider that just IF1 or its mimetics will be good enough for 100% efficacy. So, what other combinations? Looking at the wide spectrum of opportunities that we are seeing in this meeting and in the literature, I think that it would be worthy, but this is going to take quite a while, as we all know, to start trying to combine new drugs. But we will see if this is, eventually this is going to be the case for sure. But how long is it going to take? Who knows? I think all in the field have been showing that this is a combined treatment for sure. For years we have been mentioning this at the end of this talk, but still, as I was telling you, nobody's addressing this problem of using multifactorial drugs because it's kind of not so easy in the clinical terms. No? So, I'm sorry, I cannot give you a really straightforward answer.
Thank you very much.
So, okay, so we can go on. The next speaker is Javier Salvador Rodríguez from the Navarra University. He's kind of apologizing because he's an endocrinologist. I told him that endocrinologists are very welcome here. So I think he's going to feel at home here. Thank you.
So, good afternoon, everybody. First, I would like to thank the organizing committee for inviting me to talk about GLP-1 and dementia from metabolic roots to neurological horizons. Well, as the chairman said, I'm a clinical endocrinologist, so I have a rare specimen in this room. So I'm really conscious of that. So these are my disclosures. And this is the road trip I would like to share with you in the next 25 minutes or so. First, I would like to speak about from metabolic disease to neuroinflammation. Then I would like to talk about the emergence of GLP-1 receptor agonists. And then after that, I would like to position a potential role of GLP-1 effects on Alzheimer's disease. And finally, I will say some words about future directions and concluding remarks. Well, I think everybody knows that, and if we want to speak about metabolic diseases, obesity and type 2 diabetes are two prevalent and important metabolic diseases that, in fact, are connected to some obesity, particularly is associated with more than 200 comorbidities, and one of them is cognitive impairment. And obviously, there are clear connections, pathophysiological connections between type 2 diabetes and through different metabolic and vascular factors, the development of dementia. Well, if you want to have a look at the potential pathways from the transition of metabolic disease to neuroinflammation, I consider that dysbiosis, gut dysbiosis should be mentioned, also adipose tissue dysfunction, which is present very commonly both in obesity and type 2 diabetes, obviously systemic inflammation, insulin resistance, blood-brain barrier dysfunction or disruption, and neuroinflammation. Well, dysbiosis is a very common phenomenon in this kind of diseases. And you can see that due to different diverse potential causes, from genetics to bad diets, bad nutrition, mental stress, some drugs, particularly antibiotics, aging, and some diseases, for instance, obesity, type 2 diabetes, and other inflammatory diseases. Dysbiosis is common. Dysbiosis, you can see here in the limb phenotype, in the beast phenotype, that develop dysbiosis. And this dysbiosis induces disturbances in the profile of short-chain fatty acids, increased energy harvest, disturbed immune response, and this kind of dysbiosis is considered as a pro-inflammatory microbiota, which is able to disrupt the intestinal blood barrier and allow the passage of some pro-inflammatory molecules such as lipopolysaccharide, for instance, to the circulation, and then promoting through this mechanism a systemic inflammation. On the other hand, as I mentioned before, both obesity and type 2 diabetes in general has very commonly adipose tissue dysfunction. I have to say that more than 80% of patients with type 2 diabetes have obesity. And of course, in general, this diagnosis of obesity is based on BMI, which is an error. Because if you apply body composition studies, you can see that patients having a normal BMI or overweight, according to the BMI values, have obesity by body composition studies. So prevalence of obesity, real prevalence of obesity in our society is much, much higher than we thought, according to BMI. So adipose tissue dysfunction, as a consequence of obesity, the size of the adipocytes increases, and as a consequence of disproportion between the adipose tissue, adipocytes, and the vascularization, is common develop a phenomenon of hypoxia. Hypoxia promotes inflammation, release of many pro-inflammatory cytokines that induce insulin resistance. And as a consequence of adipose tissue fibrosis and all of these metabolic disturbances, the adipose tissue is losing its ability to store fat. And therefore, body fat is going to be accumulated in other places, such as the heart, such as the muscles, such as the pancreas, such as the liver, contributing to organ dysfunction. Well, as I mentioned before, here we have the consequences of gut dysbiosis and the promotion of a systemic inflammatory response. Well, we know that this inflammatory response is able to act, again, along with the inflammation coming from the adipose tissue, is able to act at the blood-brain barrier level and is able to disrupt this barrier and allows passage again of pro-inflammatory molecules and cells to activate microglia and microglial cells, in other words, to promote neuroinflammation. Insulin is really very important, a key or hormone in regulating metabolism, but insulin actions in the central nervous system are not identical to the actions in the periphery. In fact, the actions in the periphery are mediated, insulin actions are mediated by the GLUT transporter 4, whereas in the central nervous system, the glucose transporters are different, like this number 1, number 3. So in the central nervous system, the action of insulin is more related to phenomena of increasing neurogenesis, modulating apoptosis and autophagy, and acting on protein synthesis and lipid synthesis rather than regulating glucose metabolism. So I think it's important. And in this clear schedule, you can see that some drivers that curiously are the same drivers of promoting gut dysbiosis, and this are promoting insulin resistance, which is translated in metabolic effects such as hyperinsulinemia, dyslipidemia, and inflammation, and vascular effects, including blood-brain barrier disruption. And all of these factors are promoting the development of pathophysiological elements included in the development of Alzheimer's disease or diseases associated with cognitive impairment. Right, so in a summary, you can see in the left part of the slide, that from diabetes, obesity, and metabolic syndrome, along with microbiota and gut dysbiosis, peripheral inflammation and insulin resistance develops, and that induces hyperglycemia, oxidative stress, mitochondrial dysfunction, and increased permeability of the blood-brain barrier, activation of astrocytes, microglia, and therefore neuroinflammation and promotion of A-beta deposition and hyperphosphorylated tau. The clinical correlate of this pathophysiology is the clear relationship between obesity and type 2 diabetes with the prevalence and the risk of developing Alzheimer's disease. Right. Let's talk about the emergence of GLP-1 receptor agonists. Well, GLP-1 means glucagon-like peptide 1. And glucagon-like peptide 1 and GIP, glucose-dependent insulinotropic peptide, are two peptidic molecules secreted by the intestine that as a response to food injection. And these are called incretins, the GLP-1 and GIP incretins, because once they reach the peripheral circulation, are able to travel to the pancreas where they stimulate the insulin secretion by the beta cells. So this is an interesting component because if you are administered the same calories and the same composition of food ingestion by intravenous way, you don't get that incretin action, and so therefore you don't get the capacity of metabolize the glucose, the lipids, and the proteins in the same way that when you eat by mouth. So this is the incretin action, therefore, is due to oral food injection. These incretins are interesting initially for the treatment of diabetes because they increase the pancreatic secretion of insulin and even increases the insulin sensitivity too. But there's a problem, is that there's an enzyme, a protease, DPP4, dipeptidyl peptidase 4, that degrades both incretins, and that's responsible, this phenomenon is responsible for a short half-life, very short half-life of native GLP-1, only 2 minutes. And so that makes that using, according to those data, GLP-1, native GLP-1 is not practical for much of management of type 2 patients with type 2 diabetes. So also, oops. Right, sorry about that. Also, there is a production synthesis of GLP-1 in the nucleus olfactus solitarius, just in the central nervous system, and also in the olfactory bulb. From the nucleus olfactus solitarius, there are diverse connections to interesting CNS areas involved in the control of appetite and satiety, and also in the control of the hippocampus and areas related with Alzheimer's disease. However, the mechanisms or the significance of the presence of GLP-1 synthesis at the olfactory bulb level is not well known. Well, independent of that, very soon was clear that there were GLP-1 receptors in other organs, for instance, in the heart, for instance, in the brain, for instance, in the gastrointestinal system, for instance, in the pancreas. But there are no GLP-1 receptor present in the liver, in the adipocytes, not in adipose tissue, but in adipocytes, and in the muscle. So some effects at these levels are really indirect effects mediated in part by increased insulin sensitivity. This is the GLP-1 journey from discovery science to therapeutic impact. It is important. So the initial trajectory of GLP-1 starts in the 80s, and in 1987, GLP-1 was discovered to stimulate insulin secretion. And in 2005, the first GLP-1 receptor agonist constructed to avoid the attack of DPP-4 and therefore prolonging its biological effects was launched to the market. Afterwards, in the next 20 years, different GLP-1 receptor agonists were synthesized, and that's the case of liraglutide and others that were all approved for use in the treatment of type 2 diabetes. However, very soon, liraglutide was approved for treatment of obesity, and there were other molecules that allow weekly administration, whereas exenatide and liraglutide require daily injections, daily subcutaneous injections. Other compounds like semaglutide, like dulaglutide, other different were prepared to be administered once weekly, improving, therefore, the quality of life of the patients. Later on, liraglutide was approved for treatment of obesity, and also there was discovered, or there was constructed the first GLP-1 receptor co-agonist, which is tirzepatide, that in fact is now in the market for treatment of obesity and for treatment of type 2 diabetes. And the last point of this trajectory is that all these medications, or some of them have demonstrated in phase 3 trials for GLP-1 medicines improvement in interesting, important complications of obesity or type 2 diabetes, such as cardiovascular risk, such as sleep apnea, such as muscle D, metabolic associated steatotic liver disease. Therefore, there's a selected group of outstanding researchers that were awarded in the last year for the Premio Princesa Sofia Prize. It was a very, very relevant distinction in Spain, yeah, and over the world. Right, this is the GLP-1 medication. You can see the GLP-1 receptor monoagonist interact just with the GLP-1 receptor, not with other receptors. First one, the synthesizer was exenatide, lixexenatide for the second one, daily administrations, liraglutide daily administrations too, and then espregnatide, semaglutide, dulaglutide, albiglutide, all of them weekly administration. And in the upper part of the slide, you can see tirzepatide, which is a GIP-GLP-1 receptor coagonist. Therefore, it's one molecule acting at the same time in both receptors, GLP-1 receptor and GIP receptor. Right. As I have shown before, GLP-1 is able to interact with other organs and systems independently of the pancreas and the inducing delay gastric emptying, inducing interactions with the appetite satiety circuits, reducing food intake, and initially in preclinical studies, increasing neuroprotection, neurogenesis, cardiovascular protection, kidney protection, reduces inflammation in immune system, increases of insulin sensitivity at skeletal muscle level, reducing steatosis at the liver, and reducing lipoprotein secretion at the gut level. But in fact, all of these actions have been clearly demonstrated in clear clinical trials published in major medical journals that demonstrated that was effective, this GLP-1 receptor agonist in the treatment of dyslipidemia, diabetes, obesity, cardiovascular protection, including hypertension, ischemic heart disease, heart failure, atherosclerosis, peripheral artery disease, chronic kidney disease, inflammatory diseases such as psoriasis, obstructive sleep apnea, very important, particularly in patients with Alzheimer's disease, which have more risk to develop into progression of Alzheimer's disease if they suffer from obstructive sleep apnea. Also, osteoarthritis, asthma, and maybe there are some suggestions that could be useful also to treat cancer or some kinds of cancer and depression. Obviously, MASLD, metabolic associated steatotic liver disease, is really, GLP-1 receptor agonists are really a beneficial effect. There are here two important clinical trials, the ESSENCE of semaglutide, the SYNERGY NASH for tirzepatide. Well, regarding weight loss, which is one of the indications of this kind of medications, well, you see here semaglutide and tirzepatide, they are really very effective in inducing placebo. This is placebo-corrected weight loss. And very interesting, in common with all these molecules, when the patients have type 2 diabetes and dotted lines, the effectiveness in losing weight loss is clearly less than where the patients do not have diabetes. So type 2 diabetes impairs the weight loss capacity of this kind of medications. We don't know which is the mechanism, but it's a matter of fact. Well, you can see here semaglutide. This is one of the two more modern compounds. You can see here in improving the type 2 diabetes with clear reduction of A1C levels, improving the muscle D with reduction of steatohepatitis and liver fibrosis, improving chronic kidney disease, improving the symptoms of patients with peripheral artery disease, improving the major cardiovascular events, major adverse cardiovascular events in both for semaglutide, low dose in type 2 diabetes. Oral administration of semaglutide is the only GLP-1 receptor agonist that can be administered by oral. But even with that higher dose, but even in this schedule, is able also to reduce 14% the prevalence of MACEs, and even in patients with obesity and non-diabetes are also really very effective in that concept. Also, semaglutide is able to improve the symptoms of patients with heart failure with preserved ejection fraction. So this is a impressive, I think, not only semaglutide, but all the GLP-1 receptor agonists are really game changers and perhaps not only for type 2 diabetes and obesity, but also for other diseases too. If you look at tirzepatide, you can see here the effects on reducing, improving metabolic control in type 2 diabetes, reducing MACEs, improving heart failure with preserved ejection fraction, improving clearly, very significantly, the apnea-hypopnea index, which is very relevant for those patients, and improving as well metabolic-associated steatotic liver disease. Well, Professor Drucker, which is one of the outstanding researchers I showed in that photograph in a previous slide, he poses a question. Yes, a key question for disorders like lupus erythematosus, psoriatic arthritis, or rheumatoid arthritis is whether GLP-1 medicines might exert useful weight loss independent benefits through reduction of inflammation. So, well, the endocrinologists were really very happy. We are able at the end to treat obesity. Oh, fantastic, to improve diabetes without hypoglycemia. Oh, this is marvelous, marvelous. Yeah, well, perhaps the main indications of GLP-1 receptor agonists could be other. Perhaps could be used for inflammatory diseases. So I think this is a very important point. And in fact, in general, where in all organs that we know that GLP-1 receptor agonists act, such as the cardiovascular system, the respiratory tract, the liver, the kidneys, always either by preclinical or in clinical studies, in all cases, an anti-inflammatory action. Very important, because this anti-inflammatory action is able to translate into organ-protecting effect. It's very relevant. And you have to add the general effects derived from body weight loss, from improving metabolic control, lipids, including lipids, insulin sensitivity. And have a look at this. This is very important because in other classical joint inflammatory diseases, these GLP-1 receptor agonists are able to reduce in a very significant way the production levels of different pro-inflammatory cytokines. Even in osteoarthritis, which has been published in New England Journal of Medicine, the effects are really very, very important. And if you look at the one, and we clinical endocrinologists don't think in microglia or astrocytes when speaking about inflammation. And think we look a biological marker of systemic inflammation, and we use usually C-reactive protein. And you can see here that in the STEPS trial designed to test the efficacy of semaglutide, there was a consistent reduction on C-reactive protein in all these trials. And in the SUMMIT trial in patients with heart failure, the tirzepatide also demonstrated this reducing effect of systemic inflammation. What about safety? Are they safe? The answer is, are safe. The answer is safe. The main, more common side effects are nausea, vomiting, diarrhea, and constipation, particularly nausea. And this side effect happens especially when you begin the treatment. When you start the treatment, in order to prevent the nausea, you have to establish a dose escalation, progressive dose escalation, so that the tolerance is quite satisfactory. There are other side effects. For instance, retained gastric contents. I mentioned that the GLP-1 receptor agonists delay gastric emptying. So if you are treating a patient with GLP-1 receptor agonists, you have a problem if the patients have to face an anesthetic procedure, because in that situation and under that medication, you can have a risk of aspiration. So perhaps what is recommended at the present time is to withdraw one dose of weekly semaglutide or tirzepatide before the surgical procedure takes place. Gallbladder disease also has been shown to be a little bit increased under treatment with GLP-1 receptor agonists, but the data show that probably are more associated to weight loss, excessive perhaps weight loss, than a direct effect of these drugs. Acute kidney injury is really very, very, very uncommon and is linked to dehydration episodes. The other problem is the potential loss of body mass, of muscle mass or bone mass. Obviously, when a person is treated for obesity, for instance, and the weight loss is component by fat mass, the mass biggest proportion, and lean body mass. Lean body mass, including muscle, including bone. So this is now we have drugs that are really very powerful to achieve big amounts of weight loss. Therefore, we have to have a vigilance on the evolution of these potential side effects of sarcopenia. There are no data, solid data about the increased risk of pancreatitis, pancreatic cancer, thyroid cancer, or retinopathy, but there is a study, a trial, which is the FOCUS trial, we will have results very soon, I hope. So, what about Alzheimer's disease? Well, I think there's really a cataract of papers looking at the potential effects of GLP-1 receptor agonists on Alzheimer's disease. Are really, I wouldn't say myriads, but a lot of papers. So I think this figure covers all the results have been shown, particularly in preclinical models, but some of them in clinical practice too. And so you can see here that the interaction of GLP-1 with GLP-1 receptor is able to modulate different mediators at intracellular level that translates in all different cyclic MP, AKT, MAP kinases, etc. And the translation is increasing in synaptic plasticity, reduction in pro-inflammatory cascades, increase in BDNF production, reduction in apoptosis, reduction in microglia activation, reduction in pro-inflammatory cytokine release, reduction in apoptosis, increases in neurogenesis, reduction in oxidative stress, improvement in mitochondrial function, reduction in A-beta deposition, reduction in tau phosphorylation. So again, this kind of molecules may be a game changer. We have to wait, we have to study more, we have to have more studies, more clinical trials, of course. But also, there are some data indicating that GLP-1 receptor agonists are able to repair blood-brain barrier, which is one of the pathophysiological mechanisms involved in the development of neuroinflammation. So, if you you concentrate in semaglutide, in fact, it may be useful for not only for Alzheimer's disease, but for other neurological disease, but all of them, particularly in those inflammation is included in the pathophysiology. And you can see here, in all of these diseases, semaglutide is able to get benefits through in other mechanisms improving inflammation. In the case of tirzepatide, really, again, improvement in neurogenesis, apoptosis, insulin resistance in microglial cells, inhibition of microglial activation, oxidative stress, improvement in memory impairment, oxidative stress, brain insulin resistance, synaptic plasticity, attenuation of tau protein-induced neurotoxicity, and amyloid plaque expression. From a clinical perspective, most of the studies are observational studies. And you can see here that in a pooled data of 3 cardiovascular outcome trials regarding the effects of liraglutide, the effects of weekly semaglutide and oral semaglutide, there was a decrease in 53% under treatment with this agonist in general versus placebo of the patients with events related to dementia. Also, if you are concentrating semaglutide and compare the effects with other anti-diabetic agents, such as insulin, metformin, DPP-4 inhibitors, SGLT2 inhibitors, sulfonylureas, or glitazones, really, the semaglutide is really the winner in this study. And recently has been published a comparison between the use of tirzepatide or semaglutide over 7 years in patients with type 2 diabetes, and it can be seen a reduction in the cumulative probability of neurodegenerative and cerebrovascular disease. Right. Finally, the REWIND study, which is a cardiovascular outcome trial with looking at the effects of dulaglutide. It's a weekly GLP-1 receptor agonist, also demonstrated a reduction in the 14% of cumulative incidence of dementia. In the ELAD study, well, it was performed with liraglutide over 1 year, and there was a slower decline in cognitive function on the drug, and 80%, and 50% less brain volume loss on lira versus placebo. But there are some studies with no clear effects of GLP-1 agonism on cognitive impairment. Why? This is a preclinical paper, others are clinical, and well, we don't know why this happens, but that's a matter of fact. And therefore, we need more studies, and all of you and me and everybody await the EVOKE and EVOKE Plus trial in order to know whether a GLP-1 receptor agonist, oral semaglutide in this case, over 160 weeks, will be able to change the CDR, SD score, or ADCS, ADL, MCI score. Well, these letters are really very complicated, and time to progression to dementia. For endocrinologists, one of the most interesting points of this study, of this trial, is that the percentage of patients with type 2 diabetes or obesity is quite limited. So we're going to see where the effects of semaglutide, oral semaglutide, is really mediated by weight loss or not. As future directions, development of biomarkers, prediction of responders, combination of GLP-1 agonist therapy with other anti-diabetic medications that have demonstrated an improvement in Alzheimer's disease, as SGLT2 inhibitors, glitazones, other disease-modifying therapies, new medications and research into the effects of various dosages at initial stages, personalized therapy, more focused clinical trials that include cognitive tests, in addition to those aimed at determining how well novel compounds work to treat metabolic disorders. Yeah, I'm finishing. So these are the new GLP-1-based medications. There's lots of clinical trials ongoing at present with different molecules. So with molecules with amylin agonism, with molecules with 3 agonists, even, or for glipron, which is an oral GLP-1 receptor agonist that will be also, has been published today, a paper in New England Journal of Medicine regarding the efficacy of this compound. So my concluding remarks is there is a clear association between metabolic diseases such as obesity, diabetes, and metabolic syndrome and AD. This is well known. Preclinical studies show very encouraging perspectives with GLP-1-based medication as candidates for AD treatment, demonstrating beneficial effects on many mechanisms involved in the pathophysiology of the disease. There is a great deal of variation in clinical data about the effectiveness of GLP-1 receptor agonists in treating AD, which may be partially or entirely due to variations in study methodology. By addressing, very important, cardiovascular, liver, renal, and other comorbidities frequently linked to Alzheimer's disease, GLP-1 receptors provide a comprehensive approach that may improve AD and quality of life globally. And finally, more research is required to determine the significance of GLP-1 receptor agonists in the treatment of neurodegenerative illnesses, but their potential to alter the course of the disease makes their emergence an option for the prevention and treatment of Alzheimer's disease. This is my last slide, and this is to thank you, to recognize the value of Alzheimer's, the participation of the first patient, and all of you that work clinically, work on teaching activities, and on research, clinical and basic research to improve the management of this devastating disease. Thank you very much.
No tenemos tiempo, tienes que, de hecho tú te tienes que ir, pero ahora pues entonces di que si alguien tiene alguna pregunta que me la mande por correo. ¿Vale? Porque si no me quedo sin... No pues.
Okay, so let's go for the last one, the exotic moment. First of all, I want to really thank Pascual and Maria Angeles for inviting me to this meeting. Really, my gratitude is sincere, and it's a privilege I can present all this stuff into this kind of audience. And in the next 20 minutes, we will talk about parietal lobes, parietal cortex. Most of all, the posterior parietal cortex is much more larger and complex in primates compared with other mammals, and most of all, more complex and large in humans when compared with other primates. And we will talk about precuneus, but let me tell you something. Precuneus, the separation between precuneus and the superior parietal lobe, it's unclear. The boundaries are not clear. Actually, they are part of the same cytoarchitectonic region, so there's scarce information about their actual structural and functional separation. About the precuneus, the function is pretty associated with the gradients. We have body information, somatic information, and vision. So the precuneus is dedicated to the integration between somatic and visual information. And it's not phrenological to state that if we have an increase in complexity of this anatomical element, we probably have an increase in complexity of such body vision integration. Actually, we have two gradients. The first gradient is the one we have introduced right now, the anteroposterior gradient, body and vision. But there's a second one, a dorsoventral gradient separating the visuospatial function, body and vision, from the default mode network, most of all by linking body and space with the episodic memory. This allows to integrate your body into a space, but not only physical space, only a chronological space, a mnemonic space, and a social space. The body as cognitive unit, and this links the precuneus directly to some complex functions like consciousness or self-awareness. And this is reflected into the cellular structure of the precuneus. If you see the anterior and posterior region, they are associated with different types of cortex. And so the dorsal and ventral region, separated by the subparietal sulcus, they are associated with different typology of cortex. The precuneus in adult humans displays a really outstanding variation. Some people have huge precuneus and some people have very small precuneus. And this kind of variation is most of all associated with the dorsal and anterior parts of the precuneus. So the ones mostly associated with the somatic integration. And this kind of variation, so big precuneus, small precuneus, is directly influenced by the cortical surface area. So large, it's not a balloon blowing or reducing the size in terms of stretching. So larger precuneus means more cortical surface areas in the dorsal anterior parts. At present, it's not clear what does this mean in terms of functional effects or in terms of differential psychology. There's also an amazing and outstanding sulcal variation, sulcal pattern. The classical pattern is the suprachial sulcus forming a sort of H, but really the variation is huge. Most of all in the anterior part of the precuneus. The posterior part does not display a complex sulcal variation, but the anterior part, yes. And in some cases, sometimes associated to large precuneus, the suprachial sulcus reach the dorsal region, generating a complete additional anterior sulcus. So at birth, the proportion of the precuneus are already formed. After birth, in the first 4 or 5 years, there's a very slight increase in the dorsal expansion, but this is very minor. Actually, we can see that the proportions of the precuneus are almost established at birth. And so the remarkable individual variation, large bare or large small precuneus, is already settled at birth. So whatever is the source of this variation, we have to investigate prenatal factors. And for what concerns aging, this is a paper we have published a few weeks ago with the CIEN Foundation team. And about aging, we can see that if we do a shape analysis, aging is generally associated with a reduction of the ventral part of the precuneus, which is the one fading into the retrosplenial and posterior cingulate cortex. So we have seen this pattern is generalized in aging, but is a little bit more stressed in patients with Alzheimer's disease. Of course, there is a very large variation, so this difference is strong, but not enough to discriminate between normal subjects and Alzheimer's subjects. We have also analyzed the atrophy in terms of intersulcal spacing, the separation of the cortical region at the anterior dorsal and posterior front boundaries of the precuneus. And you can see that in terms of proportions, normal aging is associated to a little bit more sulcal spacing in the dorsal region, while in Alzheimer patients, sulcal spacing is a little bit more associated with posterior region. So the perpendicular scissor, so the parietal occipital boundary. Again, there's a strong superimposition anyway that hamper discrimination based only on this feature. In both the ontogenetic and aging analysis, there's a common result, and the common result is that the dorsal posterior region and the ventral anterior region, they display a different morphogenetic pattern. So the dorsal posterior region and the ventral anterior region, probably they display separate morphological blocks influenced by distinct morphogenetic and topological factors. Dorsal and ventral precuneus do not display integrated morphological changes. These two parts should be analyzed separately. So this remarks once more the importance of better understanding the continuity between precuneus and the superior parietal lobes, which often are separated in many kinds of analysis, and the importance of distinguishing the dorsal and ventral region of the precuneus, which all too often are analyzed together in the same kind of tests. So if you look at other species, this is the brain of a chimpanzee and a brain of humans. If we analyze the general geometry of the mid-sagittal brain in human and chimpanzee, you have just one very large differences. We humans have a very huge precuneus. most of all in the dorsal anterior region. While chimpanzee, they have a very small precuneus, generally shorter than the ventral region. In the case of human, the dorsal region is much longer than the ventral region. And there's a very nice, interesting analysis when dealing with fossils. I often work in paleoneurology. In paleoneurology, you used the skull to reconstruct through the morphology of the endocranial anatomy, the endocasts, which can inform about size, proportion, shape, geometry, sulcal patterns of that extinct brain. Of course, the job it's not that easy because you have very strange geometrical objects in which using grooves or depression, you have to make inferences about the original correspondence with the underlying neuroanatomical anatomy, neuroanatomical morphology. And if we can do that with some special models, geometrical models, and multivariate statistics. And if we do that, comparing Neanderthals and modern humans, two species with more or less the same brain size, we can see that we modern humans, we have the only striking differences is an enlargement of the parietal lobes, of what we can in general identify as parietal lobes. We don't have, of course, the possibility to analyze all the elements of the parietal lobes, but the differences are associated to a general expansion of the inferior parietal lobules and a general elongation of the superior parietal lobules. So, Homo sapiens display a larger parietal cortex when compared with any fossil hominids, including Neanderthals. And it is very interesting to see that this change, this morphological change, is not associated to the origins of our lineage. Homo sapiens' origin is chronologically dated to about 200, 300,000 years. But we can observe this bulging of the parietal lobes only in a range period between 50 and 100,000 years. And I please ask you to remember this number. Remember that the bulging of the parietal lobe in Homo sapiens did happen something around 50 and 100,000 years ago. So, you know that the precuneus is very crucial key in terms of network organization, in terms of local and global hubs, and in terms of structural and functional networks. Actually, it is the place in which the structural and functional networks do meet in terms of topology. And it is directly involved in the Folmo system, and probably for this reason, it displays a very high glycolytic index. So it needs a lot of energy. And if the metabolism is strong, that metabolism do produce heat, thermal production. And we have tried to model how brain heat can dissipate according to the change in brain form. We can do that with Neanderthals. So it is interesting to see that Neanderthals or whatever other extinct hominids, they display flat parietal. And that flat parietal is very close to the core, thermal core of the brain. So it is very good surface to dissipate heat. In turns, if you consider modern humans, we see that the bulging of the parietal cortex hamper a dissipation of the heat of the central core of the brain. So we can wonder if this large production, heat production, can generate some thermal management process. And probably it's not by chance that only modern humans, we have a very complex middle meningeal artery. All the other extinct hominids, they have a very poor middle meningeal artery. Only modern humans, we have a complex meningeal networks, most of all on the parietal surface. So it has been hypothesized that this is a sort of radiator to cool the endocrinial surface. So if we do this modeling, we see that the region, the real core of the heat production in a human brain is more or less the retrosplenial cortex, the inferior region of the precuneus. And it's also interesting to note that this region has some vascular constraints. Actually, the anterior cerebral artery reaches the precuneus just with its most terminal posterior branches, and the posterior cerebral artery reaches the precuneus with the most terminal anterior branches. So the precuneus is a sort of watershed region. It's a sort of nobody's land. I mean, the anterior and posterior cerebral arteries say, it's not my job, it's your job. and nobody takes into account what's happening there. And in the 90s, they discovered hundreds and hundreds of very tiny vessels joining the diploe of the skull with the meningeal layers. They supposed that these hundreds and hundreds of tiny vessels could serve thermal regulation. But very recently, in 2018, there was a very strong evidence suggesting that these hundreds and hundreds of very small microvessels are directly involved in inflammatory response, immunological response. So the marrow of the cranial bones produce the inflammatory, the immunological response to some necessity of the brain tissue and inject the biomolecular response into the brain below the arachnoidal barrier through these hundreds and hundreds of micro vessels. And interesting, what is the region with larger and more dense microvessel? The dorsal parietal region is the region in which these vessels are larger and most densely organized. This is a new research line that we are implementing at the CIEN Foundation and in collaboration also with the University Hospital of Milan and the King's College in London. So the ventral region of the precuneus, or better, the retrosplenial cortex, has many structural and topological constraints. I applied network analysis in a very strange way, not to analyze connectivity of the brain, but to analyze the topological organization of the anatomical element, contiguity. All these brain regions are in touch, and this physical contact generates structural, spatial constraints. If we analyze the human brain with this approach, with the network approach to topological organization, we can see that if we analyze the degree, the number of contacts, the retrosplenial cortex is the region, the mid-sagittal region with most difficult topological situation. If we consider the betweenness, which is the role as bridge between different regions, in this case anterior and posterior region, we see that the retrosplenial cortex is one of the two strong bridging regions. And if we analyze closeness, there is a sort of proximity of all the other regions. We see that the retrosplenial cortex is one of the most of the region expressing a very high centrality index. And we have also some other structural issue here. For example, the retrosplenial region display a very strong morphological variation with structural constraints, biomechanical constraints, because it is the anchor point of the tentorium cerebelli. The tentorium cerebelli is a very large connective sheet that, in terms of morphogenesis, represent a relevant biomechanical tensor during growth and development. And the retrosplenial cortex is directly attached to the tentorium cerebelli. Then, if we do an analysis of modularity in terms of recognizing morphological blocks, we can see that the retrosplenial cortex is part of a morphological block integrating many subcortical elements together. We have also seen that it is part of the thermal core of the brain, and we have seen that it has a difficult situation in terms of vascular supply. So all this stuff suggests that the retrosplenial cortex, the inferior part of the precuneus, has many functional and structural constraints. And we know that precisely here, an important key for the default-mode network, precisely here in the same region, we have the prodromal atrophy, prodromal effect of the atrophy progression in Alzheimer's disease. So it is precisely in this region of high topological burden, high morphological burden in the sense of loads, structural load of different elements, it is precisely here that we have some key step of the progression during the Alzheimer's disease. So more than 10 years ago, we proposed a sort of hypothesis asking whether the evolutionary parietal anatomical complexity may have generated some functional and structural constraints, new phylogenetic structural constraints that may have been increased the vulnerability to some kind of metabolic, thermal, or vascular load, may be associated with influence on protein structure or their clearance, metabolic residuals. We proposed this hypothesis 10 years ago, and this hypothesis has been updated very recently, 1 year ago, in this book edited by the Oxford University Press entitled The Evolutionary Roots of Human Brain Disease, that takes into account very different kind of disease. So when we proposed this stuff, the reaction was not very good because precuneus was not a key element of the hypothesis on Alzheimer at that time. Nowadays, you know that things are definitely changed, and nowadays everybody recognizes the role of the precuneus in the progression, in the early progression of Alzheimer's disease, and there are so many papers associating the progression of typical AD to, in a prodromic stage, to hypometabolism, most of all hypometabolism, which means that something is not working well there. Hypometabolism of the precuneus, most of all of its inferior region. And interestingly, you know that we have seen the talk by Juan Fortea about apolipoprotein. Juan sent me a couple of years ago these papers, which is very interesting because here you have the distribution of the ApoE4 allele frequency. And you can see the distribution of this allele is definitely organized along a north-south axis of variation. In anthropology, when you find some features, genetic or morphological or physiological feature, organized in north-south trends it looks like selection is at work. Selection possibly associated with some climate stuff, infection stuff. Well, you know that after the ApoE4 allele, we can observe an evolutionary changes. ApoE4 evolved into an ApoE3 and then an ApoE2 allele. And the ApoE2 is protective against AD and other inflammatory diseases. Well, the nice stuff is the chronology of the evolution of the ApoE2 allele. It's approximately 80,000 years ago, which is, by the way, exactly chronology suggested for the parietal bulging. This may be by chance or not, so probably it should be considered with a more general view. And back to the models, back to the network models, topology. Can you remember the stuff? This network is not network of connectivity, it's network of topological relationship, spatial relationship. This is associated with the topological constraints associated with the fact that this anatomical region are embedded into complex anatomical environment with many neighboring anatomical elements. Well, we have compared the cerebral organization of humans with the cerebral organization of apes and chimpanzee. And when compared with chimpanzee, we humans have only two new evolutionary regions that are very difficult in terms of topological, morphological burden. The second region is the retrosplenial cortex, as we mentioned before. But the first region, the one which it's most difficult to handle in terms of topological arrangement, is the para-hippocampal gyrus, which is another region of interest for this audience. So this is my webpage, and you can find here all my papers and also my dissemination articles and some scientific and dissemination books on all these topics. Thank you very much. So I guess it's questions time, correct?
So, a nice talk. I like evolution, so and neuroevolution seems to be also a very nice topic. So I thought that this 80,000 years coincides more or less with the expansion of Homo sapiens to Europe and Asia and all this stuff. And this correlates also with the proportion of this ApoE4 that is highly represented in the African population. So how you look also to the precuneus area and these expansions in Africans versus Eurasians humans?
Yeah, we published some years ago a study of precuneal morphology and human diversity. It was not biogeographical in the sense that we consider it racial differences, but all US people. So it was not a real geographical analysis. It was a racial analysis, but within the same culture, and no differences. So there were no differences, and all the variation, the precuneus variation, as far as we have investigated, and at present we have published some 15 papers on precuneus variation. There's no racial differences. There's no sexual differences. It's an idiosyncratic variation, individual variation, so large, so outstanding that it hampers very fine statistical analysis because it generates a lot of noise. Most interesting things would be proper psychometric analysis to test what it means to have a very large or very small peculiars. Guillermo?
Yes, fantastic talk. I have a couple of questions. One, I'm very intrigued about those microvessels. And since, you know, I see it from the neurostimulation point of view, we always think about stimulating the brain, but between the brain and our stimulator are those microvessels. So what do you think, or do you think can then be involved in a stimulation situation? So how they would react to electric field, magnetic field, or even ultrasounds or other techniques. So could they play a role in the short-term or long-term effect, especially thinking about the long-term effect? And that would be my first one. Then I give you the
microvessels have been described as involved in inflammatory response just a few years ago. And in terms of anatomy, morphology, and variation, there are just 2 papers of mine, no more information. So it is really a brand new research area, and the information available is very few. I totally ignore the effects of whatever electromagnetic field on this vessel, but surely with this situation of microvessel, which probably have a crucial physiological influence, there are so many physical actions that we commonly perform during our life that are probably harmful because you know, all the stuff about, all the discussion about car accidents or boxing or football players, you know that there are so many vascular drawbacks of all this stuff. You can imagine that if all this microvessel has a key role in physiological response of the brain, there are much more physical action that are problematic before arriving to electrostimulation or whatever. Of course, it would be interesting to test the possibility that this kind of analysis can have an influence or being influenced by these elements.
Very nice. Second question is very practical or deeply philosophical, depending how you see it, which is when you talk, and it's a little bit tangential to the talk, but it affects very directly my research and many others. The concept of, you talked about normal aging, and of course when we compare in general a group of patients against normal subjects, what is normal aging? You mean it clinically normal aging, biologically normal aging, and how can we really do that comparison in a rigorous sense? And now that we are going toward the biological definition of diseases that we heard today, we might have to move toward the biological definition of normal aging. So when we compare our control group, has to have all the negative biomarkers so that we exclude prodromal diseases. Of course, this is not a problem when you study 20 years old students, but it becomes a problem when you choose your normal controls in an age-matched neurodegenerative context.
Yeah, well, there is a long-standing issue. My degree in I got my thesis in biology more than 30 years ago on aging. So it is 30 years that I'm that I'm mumbling about exactly this issue. So we have to surely separate the philosophical question, what it means to age, from a practical experimental approach. For example, in our case, it is just a control with no Alzheimer, without Alzheimer. So people that they they're 80 years old, but no dementia. No dementia, no Alzheimer, nothing that can suggest that, they are involved in an AD process. I think we have to separate the practical definition, which of course can change depending on the research target, and the philosophical issue, which is definitely wider. There are many evolutionary interpretations of what does it mean to age. We can talk about it later.
Okay, thank you. Now we have a last minute. Okay. Thank you very much for your attention, and I hope that you have enjoyed this last session.
Just a few words. Unfortunately, Pascual and Maria Angeles are not here attending another business, but in the name of all the people related with the organization, thank you very much to the speakers, fantastic section, and thank you very much to all of you for joining us. I particularly also want to thank the people from the Fundación CIEN, represented here by Aina, that do a wonderful work. And please remember that this afternoon there is also a continuation of this Congress in the form of a socio-clinical session involving the association, and we have the beautiful performance of our friend Fofani that will do a performance with a friend, and this can be a very good experience if you're still around. So I hope that you enjoy the Congress. Thank you very much again, and please go for the lunch.